To summarize, I guess it's because pharmacists are in your local communities, right? And most of you, especially in Georgia and Metro Atlanta, you'll see a pharmacist practically within the 5-mile radius, maybe 20 of them in any respective community. You do not need an appointment to see a pharmacist. You do not require a call contact information. You can walk into a pharmacy. It's happened all the time. I know I'm the co-chair of FAIR, but I'm also an executive at Rite Aid Pharmacy. And I manage right now about 38 pharmacies for the organization. And so what you heard today was from a clinical pharmacist who works for Rite Aid, is the fact that you will more likely be able to receive integrated care at a pharmacy, being able to receive emergency care at a pharmacy, being able to hopefully receive some communications and education to help improve self-management in a pharmacy than you would in any other area of the healthcare sector. I don't think pharmacists are utilized appropriately, which is probably why I switched careers. I was with GSK at the time, and I decided to go back into the community setting. I decided to inspire about 70 pharmacists for Rite Aid. We have about 16 asthma certified educators in the communities, and those are things that are very different within that Rite Aid network than it was prior to me joining Rite Aid. So to answer your question, you're going to have access to comprehensive, affordable, quality care when you walk into a pharmacy.
The illusion in any conversation is that conversation actually took place. And with so many people that physician or that healthcare provider has to talk to, did you understand what I said? Yes? Okay, great. And then you move on. So one of the things that I saw is happening, and this is a tremendous burden, I suppose, or tax is probably the best way to say it, on resources, is to actually get involved with them. And particularly the more often that they come back, they're not, obviously not getting it. So one of the things I saw was happening in Spalding County is that they, those people who repeatedly come back into the ER, they will actually send out a community paramedic. They will actually spend 2 hours. They're not taking a computer, they're taking a tablet, a pen, and they sit there and they talk to them, and they get to know that they get to understand exactly what they mean by what they say. And so then as a professional, they can begin to identify where the breakdowns are. Does that answer your question?
Yes, definitely. Thank you.
Earlier I talked about how that evening she was not provided any medication. I scoured protocols to try to understand what is the protocol for a pediatric asthma attack. And at the time, there wasn't one. There was one for an adult asthma attack, but not pediatric. And when I asked the fire chief that showed up that evening, that began giving directions, I said earlier that the answer we got was, will we treat the child not breathing? 2 years later, I asked him, what is the protocol? And he said, I don't know, I had to look it up. So there should be some responsibility somewhere. And knowing Brennan, she would, as she survived that night, she'd be the first one thanking that sent person. So there should be accountability across the board on training. And I know there's a lot of training going on, but we all know asthma affects over 10% of our kids. I mean, it's out there. And does everybody really know how to recognize and treat it? I think that would be her sole goal, would be training.
Being engaged with family members, neighbors, everyone that you could touch out in the community that can reach and help each other needs to get information to help an asthma patient or a person that's suffering from asthma. So one of the innovative things that we're doing is trying to give complimentary free education to everyone that we can reach in the community. It's very important not only for the patient to know what asthma is, but their family members, the pastor, the preacher, your local store vendor, just everyone in general. So we're infiltrating communities now. We are more focused on family and community. And I think with that, we'll see a change in the outcomes with asthma. The more people who have education and the more knowledge, simple knowledge that we have about asthma, the more ready we'll be to help a patient or a child that's in need of any type of rescue.
I used to work at the law firm Solomon and Jeffries, and for about past 5 or 6 years, our practice has focused primarily on civil litigation in the areas of mold and environmental health. These could be issues ranging from any toxin in the environment, whether it's mold, fine particulate. We have one case right now that involves cutting agents used in a methamphetamine lab above my client's residence. And we represent not only tenants in a landlord-tenant situation, but we also represent homeowners in construction defect cases. And occasionally we'll also represent environmentalists or remediators, whether in regards to a claim against an insurance company that owes them money or where a homeowner wrongfully, as we believe, alleges that they haven't done their job properly. I think this summit's actions are extremely important to the area of law that we are practicing in, because right now, Georgia doesn't have any standards as to either what are acceptable fine particulates in the air, what are the standards for environmental air quality. It doesn't have any standards for how they should be treated. And so you can imagine if you were suing somebody because you were involved in a car accident where you or a loved one was severely injured, imagine going into that courtroom and instead of being able to just introduce a ticket or a citation showing that someone was a drunk driver or moving down a 35-mile-per-hour street going 100 miles per hour, imagine if you had to prove to the jury first and foremost that that was an unreasonable speed in the first place. Imagine you had to prove to them that it's probably not a good idea to drink 8 glasses of scotch before going for a midnight cruise. But that's exactly what my clients face every time they enter the courtroom. Because Georgia doesn't set any limits for what type of filter should be used. It doesn't set any limits to how much mold is acceptable in the air. And it doesn't set any limits as to how this problem should be addressed. Can the landlord put a sheet of paper into an HVAC system? Maybe, maybe not. It's up to the jury to decide that. So this summit's activities are critically important to my clients getting justice in the long run and being able to address these personal injuries that arise from exposure to the environmental hazards that they see every day.
Yes.
Well, as a pulmonologist and an asthma physician, I think one of the key components is making sure that the diagnosis is accurate. So we spend a lot of our efforts in our clinic is to make sure that when someone comes in with symptoms, they may come in with symptoms of cough, they may come in with symptoms of chest pain, they may come in with wheezing, but those are a wide variety of symptoms that they come in with. So making sure the diagnosis is accurate, number one, because asthma gets slapped on as a diagnosis frequently. The second issue is basically learning how to help the patients realize that it's a chronic condition. It's not something that can be cured. So it's really, really important in terms of management. So we spend a lot of time in terms of helping them understand the medications that they need to be taking, as well as how to manage exacerbations and other things. So we teach them and spend a lot of time on education. So not only diagnosis, management in terms of treatment, but also the education piece. And the key piece that we talk about is environmental exposures and making sure that we can avoid triggers. And I know that was a primary discussion or a topic of the summit today. So that is something that we spend a lot of time on. So, and all the triggers are different per person, so we personalize a lot of that, trying to understand what triggers trigger certain people and not others, and so that's a very important element that we spend a lot of time on in terms of making the assessment correct. And then at that point, if there are patients that we have in our clinic that have multiple exacerbations and are very difficult to manage and control, and we emphasize on, we specialize in that in our Emory, the Asthma Allergy Immunology Clinic. And we focus a lot of our attention, so we get a lot of referrals from allergists, as well as primary care physicians, as well as other pulmonologists because of our subspecialty in that area. And so what we do is we're very interested in understanding the biology of that, the immunology of that, and there are some really interesting and very exciting therapies that are coming down the pike. They are some new biologics, which are basically, as many of you know, these are medicines that have been implemented in patients with chronic conditions such as rheumatoid arthritis or other autoimmune conditions. And so these are helping patients manage their diseases because we can't cure it. So the key element is management and control, and emphasizing the importance of that and empowering the patients for that. So we have we're working on clinical trials for some new biologic agents, and there's some really exciting immunologic agents that are coming down the pike for patients who are very, very difficult to control asthma. So again, diagnosis, therapy, personalized approaches of understanding their diseases, education, and then implementing new therapies that are really exciting that I think are going to be revolutionary in terms of managing asthma.
Much of the work that I've read about medical causes of diseases have been concluded to be not a single event that causes much of these things to happen, but rather a series of events. Much like they talk about accidents, that usually one thing doesn't cause an accident, that there's a variety of things. In the chain of healthcare, there may very well be something that the person has eaten that has caused a reaction in their system that has allowed some bacteria that they have inhaled or a virus that they've inhaled to do something else that goes along with a toxin from or that makes them susceptible perhaps to a toxin in a mold spore, or they have asthma and is exacerbated by the idea of background particulate and allergic reaction to those things. So there's a series of things often happens in many of the medical cases, and cancer is one in particular that they talk about, a chain of events that occurs. We believe, I've come to believe, and I've become a stronger believer in this in the last 3 years working at the Asthma Coalition, that the things in the indoor environment where people spend 90% of their time, the things that people are breathing, play a role in those linkages. There are some studies that suggest that 10 to 30% of all diseases associated with particulate come as a result of indoor particulate that's found in the indoor air. We do a lot of things in the outdoor air to try to clean up the outdoor air, but when you think about it, where do people breathe the outdoor air? They breathe 90% of their air, they breathe indoors, and some of the air from the outdoors comes in. I have a concern about poverty in parts of Atlanta. One of the problems with poverty is they live in substandard housing. When they live in substandard housing, they don't have good air quality. They're breathing in a lot of things that they really shouldn't breathe in. They don't feel well. The prevalence of asthma is higher in some of those communities and other diseases as well. They don't do well in school. They don't do well in school. They get out, they don't get good jobs. They don't get good jobs, and they wind up having to live back in substandard housing. So the notion of health in general has an influence on a lot of other things in the community, and certainly the costs. There's some studies that we've looked at that suggest that Fulton County spends some $24 million on emergency room visits and hospitalizations that the population are not able to afford or to be able to subsidize those things. Imagine if we could redirect that $24 million towards other things in the medical field, other kinds of care that we could be doing. So we believe that, and on a national basis, some 25% of all emergency room visits are a result of breathing difficulties, which would include all of the COPD diseases. They're all affected by what you breathe. So when we're fixing the indoor air quality for an asthmatic, we're also fixing it for a COPD person. We're also freeing up resources that can be used at a time we're trying to have national health care that can be redirected to other kinds of diseases. And we're eliminating some of the toxins and other things that are playing a linkage role in a variety of other diseases. And I can go down the list of the toxins in indoor air quality, especially just as only associated with mold spores without regards to all the rest of them. And many of them are linked to diseases, the kidneys, the liver, the brain, the heart, the lungs, all of those kinds of things. So by cleaning up the environment, fixing the indoor air quality with filtration, dehumidification, good housekeeping practices, and potentially a small amount of makeup air, we're affecting a whole cross-section of the community in a much more positive way than just asthma.
Great, thank you.
The first important question is to know when to go. And so let me start with this. There are usually about 4 reasons why people don't go. It's inconvenient to go. That's about education and attitude. It's I don't have the means to go. That's about education. I don't have the money to go. That's also about education. And then there's the last one, I'm just tired of going. And I've had a significant number of people die just because they're tired of going and getting seen about. So I'm setting that as a context. So when to go, there's currently, as I checked around, there's not a set protocol for when you should go to the hospital, at least not locally here by the people I've talked to, the emergency care providers I've talked to. NIH has a protocol where it's a 4-step, and it says that mild intermittent asthma is if you're having less than 2 symptoms, bouts of symptoms a week. That could be wheezing, it could be the persistent cough and that kind of thing, or less than 2 at nighttime per month. And that between these flare-ups, that there's nothing really much going on. That's something that usually we can handle at home. We have our own home nebulizer treatments or the rescue inhalers. Those seem to do well in those kinds of situations. The second level is the mild persistent asthma. And it says symptoms more than 2 times a week, but no more than once a day. Has his or her activity levels may be affected by the flare-ups. Kids will run and run and run and run. And when you start seeing them finally slow down, you know that there is a true issue going on. And experiences nighttime symptoms more than twice in a month. It's at that point that a personal care physician is probably the best person to go see, because then they'll look at some more long-term things and begin to address the issue of what may be going on in the home, or what new exposures, maybe it's a change of season or whatever. The third step, the NIH identifies as moderate persistent asthma. Symptoms every day, uses his or her rescue medication every day, has flare-ups twice a week or more, his or her activity levels may be affected by the flare-ups, and experiences nighttime symptoms more than once a week. It's usually by this time at moderate persistent asthma that we encourage you to call 911. Our current protocols, we're under Fulton County Emergency Medical Services protocols. We have a big thick book, and we all seem to be other surrounding counties. We all abide by that same those same protocols. But by the time that we come, our first level, or what we consider mild, is wheezing is present. They're breathing about 30 times a minute. They can speak in good sentences, but there's wheezing. So I took my 4-year-old into my primary care physician, my pediatrician, and because he was wheezing. He had childhood asthma. And she said, well, Mr. Allen, you should have brought your son in 2 days ago, when he started first having this cough. I said, no, it's okay, I'm an EMT, I got this. He just started wheezing this morning. Mr. Allen, you should have brought him in 2 days ago. And I said, that's all right, I got it. She said, I'm the doctor. And I got it in that moment that, that I'm always thinking of the emergency situation, but it starts way before then. That was 27 years, 5 months, 6 days ago, and I'm over it now. But the idea is that that's how we get, that we think that we know a little bit, and that the more we're educated about when there's a distress, that's when we should get involved. So that's the when to go. The next part is how to go. So obviously if you're staying at home, that's no issue. If you're going to your private care physician, your personal car or friend's car or whatever, that's fine. I'll say that because we get called 911 to go to the doctor's office. You actually will be better served to just go in your own personal car. As we get to the next level, though, where there's wheezing or there's moderate distress, call 911. And by all means, if at any point you think, I'm not sure, call 911. It's our pleasure to come out. We're only 4 to 6 minutes away. Usually, I'm with the fire department, so we have our stations geographically placed so that we can be there in 4 to 6 minutes. The ambulance may take a little longer, but we can immediately begin to assess and to serve what might be going on. A lot of times, parents will come and they just don't know that this is a severe situation. Fortunately, I've seen 65,000 calls in my career, so across the room, I know this is bad. Or across the room, I know, maybe not so much. But at least I can bring that to them right away, and they get that in 4 minutes. So my important point that I want you to take away is that if in doubt, call us. And that will help us to know, to tell you how you should go. I won't tell you to take an ambulance if you don't need it. And then where to go. The where to go, I always believe in sending children to a children's hospital. They just simply, they got that down. They got that packed. They're the best at it. Unless it's life-threatening and that children's hospital is so far away that you need to go to the closest facility. So here's what you say. There's so many things going on when you walk, when 911 walks in. They're thinking, man, we've only got so much time to do the next thing. If you think that your child should go to the hospital, or rather you know they're going to go to the hospital, I encourage you to say this, lock it in. I would prefer to go to a children's hospital unless your professional opinion, in your professional opinion, we should go to a closer hospital. And the reason you say it that way is that they're racking their brain. They're thinking about, what do I need to do next? Where's the closest hospital? They're evaluating multiple different things. So if you say that to them, that's their language, and that will get in. And they'll, if they don't go to a children's hospital, that it's because they needed to go somewhere closer.